Hi, this is the fourth video of my WBC neoplasm series, and I will be talking about follicular lymphoma. Follicular lymphoma is the most common indolent non-Hodgkin lymphoma in the US. By the word indolent, what do you mean? Indolent means slow growing. I mean, this lymphoma, I will explain to you later that why it is slow growing, and it presents in adults generally who are in their fifth or sixth decades of their life. So the origin is from a centrocyte. If you want to know about centrocyte, you can check out my previous video named Introduction to WBC Neoplasm, in which I have in detail talked about centrocyte and centroblast. So what happens in the pathogenesis? The pathogenesis, or what causes this? What happens is that there are two chromosomes, chromosome 14 and chromosome 18. There is a gene, locus gene on chromosome 18 here, called the BCL2, and here is the chromosome 14, which codes for which is called IgH. IgH. It codes for the heavy chain of immunoglobulin or the antibody, and the BCL2, as we know, is the anti-apoptotic protein. What happens is that, as I told you, that when the centroblast is becoming centrocyte, dividing into centrocyte, then it is taking a risk. It is producing a lot of mutations in itself. So when it is producing a lot of changes in its DNA, there are chances of chromosomal translocations, obviously. So what happens is that when the BCL2 gets translocated, this segment here flies and just juxtaposes besides the IgH. And what happens is that the IgH, the immunoglobulin heavy chain, it is gifted with you can say a promoter region, or you can say it is very transcriptionally very active. So if the BCL2 gets juxtaposed, or it is just beside the enhanced, you can say, in transcriptionally active region of the IgH, immunoglobulin gene, which is coding for the heavy chain of immunoglobulin, so it also starts getting overexpressed sorry overexpressed, and this leads to all the problems, as we talked about in CLL SLL also, that why BCL2 overexpression is not a boon but a very big curse. So what if we talk about the clinical features, that what will the patient present to us? So he will present with a generalized kind of fever, which you even he won't be it will be very difficult to explain, because there will be no microorganism, nothing, but still he is having fever, and he will have fever, fever not, anorexia, and painless lymphadenopathy. Mark my words, not painful, painless lymphadenopathy, and you can say HS megaly, hepatosplenomegaly. We will also see that. Pardon my writing. HS megaly, hepatosplenomegaly. So this is how we can diagnose someone clinically, but I think this will not provide us a sure shot diagnosis that he or she is having follicular lymphoma. We need to go a bit further. So I will in detail discuss the diagnosis of this diagnosis. So if we order a complete blood count of this patient, what we get is lymphocytosis. Obviously the lymphocyte count will be very high, and the lap nap ratio is also elevated. Now what is the lap and nap? Lap stands for leukocyte alkaline phosphatase, and nap stands for the neutrophil alkaline phosphatase. Now see, lap leukocyte alkaline phosphatase is an enzyme which is present in lymphocytes, and if the lymphocytes are elevated, this enzyme is also elevated. So yes, if the lap score is elevated, generally it is elevated in viral infections, in chronic infections, but in cases of lymphoid malignancies also it can be elevated. Now if we do the lymph node biopsy, not an aspiration biopsy, we get something very distinctive. You can see the follicles here, they're so crowded. If I make this out one follicle and this follicle, just see the distance here. It's minimal. It's like they have submerged into one another. And if I go to this normal lymph node, you see it is so properly spaced out. Here one follicle, this much distance, one follicle, then we get, yes, one follicle, one. You see, it is so properly spaced out. These lymphoid follicles, these arrows, you can see the pointing here, they're so evenly spaced out, but here it is compressed, it is going into one another. And just like I told you that centrocytes always lie in the center of a follicle, so they will go they will always try to, just like I told you that a lymphoid follicle is properly like a circle, but if something starts unevenly and even multiplying in from all directions, it will try to push the circle in some haphazard way. So that is why you see that this follicle is not properly that circular too, it is not having, it's not retaining its geometry, and also it is, it is effacing other follicles, it is compressing them, and there is no space between them. That is what is happening here. So in a lymph node biopsy, we get, during a lymph node biopsy, yes, we get packed follicles, and effacement of the dark zone. Now, in my previous videos, I have talked about the dark zone and the light zone, so you can check that out. But let me discuss it one more time. So, yes, in a lymphoid follicle, we have a dark zone and we have a light zone. The dark zone here, and we have a light zone here. So, in the light zone only, there are centroblasts and centrocytes, and in the dark zone, we have naive B cells. So, obviously, if something from the light zone is multiplying very much, it will obviously thin this out. The dark zone will be thinned out. So that is what happens here. The dark zone is thinned out here. You see, the lighter zone is more abundant here, more big, and we don't see a clear distinction between the dark zone and light zone. It has vanished. So this is what we get. If we take the gross image, obviously this is not for diagnosis. You don't take out the organs of a live patient. So if we take the gross image, we see, this is the gross image. We see prominent white nodules. Now, what is this white nodules? You must have heard about white pulp and red pulp in spleen. White pulp composes of the B lymphocytes, and the red pulp is, I think, macrophages, uh, which consume the RBCs, and it also consists of sinusoids. So the white pulp is generally white in color. That is why it is called white. In a normal spleen, it is very small and very not that apparent like it is apparent here. So what happens is that obviously if the lymphoid follicles, which is the white pulp here, if it starts getting very large, then it will be very apparent. These whitish structures. That is why it is apparent, as white nodules. So in gross image we get that. And if we do the PBS, then in 10% cases we get lymphocytosis. In 10% cases, though it is a lymphoma which presents generally in the reticuloendothelial organs, that is why it has been called lymphoma. But yes, in 10% cases we get lymphocytosis, and we see centrocytes in the blood. And also, first let us talk about the appearance of centrocyte and centroblast. See, the centroblast was a multiplying cell. It multiplied. It had to multiply. It was producing a lot of centrocytes. So, since the multiplication is going on very actively here, it has multiple nucleoli. You see, multiple nucleoli here. If I take a centroblast, you see here multiple nucleoli. But a centrocyte, in fact, is a mature cell, so it does not multiply. Its nuclei is cleaved. It feels like it has been shaven or cut. It appears very sharp. It has sharp contours. So that is what we get here. And if we see centrocytes, yes, this one is a small one, but still, let me mark one out for you here. You see the nuclei is very small and sharp. So this is the centrocyte. Now, if you will say, I see a difference between these two images. What happens is that this is a normal lymphoid follicle, and here you can see centroblast, centrocyte, and a lot of tingible body macrophages here also. Now, what are these tingible body macrophages? See, the centroblast, when it is multiplying to produce centrocytes, they, not all centrocytes are perfect. Most of them die. So who will remove them. It is a debris, right? We don't need centrocytes. They are actively undergoing apoptosis. So here the macrophages play a role. They try to phagocytose them and clean the lymphoid follicles. Now, in a malignant lymphoid follicle, which is having increased expression of BCL2, would you see any tangible body macrophage or any macrophage actively consuming our centrocyte like it is consuming here in a malignant? No, you won't see it. This is the image taken from that only. That you won't see. Though I see a dendritic cell, which is also involved in antigen presentation, but I won't see any a macrophage which is consuming the centrocyte which is undergoing apoptosis, because it is overly expressing BCL2. Why would it die? He or she will accumulate a lot of mutations inside it, and he will undergo mutations, as much mutations as he wants to, because of the immunity which has been granted by BCL2. So that is what is happening there. This is of a malignant lymphoid follicle of follicular lymphoma. So that is what we get in uh, lymph node biopsy and the appearances of centrocyte and centroblast in a microscope. Now if we do the immunohistochemistry, so you guys tell me the immunohistochemistry, because for till now you must be having them on your fingertips: CD5 negative, CD23 negative, and BCL2 positive. Now you see the BCL2 positive. If I do the immunostaining for BCL2, no, BCL2 is a cell marker, so we use antibodies which act against those cell markers and they try to give us a color, an active color. So for example, here it is brown. So you are seeing that this whole lymphoid follicle is brown. And if I do it in a normal lymphoid follicle, no, which is not malignant, we get the brown staining only on the peripheries. It is not that diffuse. You see, the whole lymphoid follicle is brown, not a single color. You can say not a single thing has not been shaded by brown. Even they have invaded here too. They have reached the cortex of the lymph node. The infiltration is so much. So that is what I'm trying to say, that this image is very beautiful. So that is what I'm trying to say, that BCL2 is a very sure shot marker for us, which helps us in diagnosing follicular lymphoma. And that too, when we get CD5 and CD23 negative, then we are sure shot, and you can say we are just 100% sure that yeah, this is the case of follicular lymphoma, and that's how we proceed in our patient. Now if you are talking about prognosis, then the prognosis is not good. And generally what happens, that this, though it presents it at a very later decade in life, it comes just like, there's a lot of similarity between this and CLL and SLL. Just like in CLL SLL, they had BCL2 overly expressed, and then just because they are not like, they're not a blast, they're a site, so they will not multiply that much, they won't have that much power, so they will take some mutations, they will take some time. Okay, let me become malignant. So that is what is happening here too, and when they come with the full force. That is why the prognosis is also bad. Now it becomes worse, even worse, when the follicular lymphoma turns to DLBCL, or our diffuse large B cell lymphoma, about which I'll be talking in the next videos. So yes, the prognosis become very bad here, and I am ending this session of follicular lymphoma. If you like this video, give thumbs up, comment down the comment section, and please subscribe. It motivates me to produce a lot of videos like this, and seeing you people comment and like my videos and watch my videos, it even compels me to help you, that you guys are stuck there and you can't understand Robbins and whatever terminologies are given there. Even I am a student just like you, so I want to help you out. And I will see you in the next video. Till then, bye bye.